a warrior in the advocacy of getting the rights of the CHDs somehow like recognized at least. And she is one who is in the advocacy mission for insurance policies and how to make the Disability Act, wherein CHDs are also made inclusive, so that our children really, they're not just saved and given a life, but a livelihood as well. So it's the most important thing. You just cannot like leave them just as a surgery table or saying that, okay, we have fixed the heart, the life is also to be fixed. And so let me just call upon Dr. Smita Mishra, ma'am. Please, ma'am, to you. And she's a poetess as well. I mean, her poetry is so good and everything is about CHD. So moving on to Dr. Smita Mishra, ma'am.
Thank you so much for this opportunity, and I'm so impressed by your zeal, and everyone who is presenting over there has a special heart for these kids who are having congenital heart disease, and it's a great thing for me. So I should I start with my poetry, huh, Sajni?
Sure, ma'am.
Okay.
Sure,
So,
sure,
yes.
ma'am, sure.
Is dedicated for rights of a child with heart disease, and it is dedicated Valentine Day from my side for the children with congenital heart disease. So this child is addressing, "Oh nation, I am your youngest citizen, who was born with a messy heart. To unsuspecting parents, they cried to see the sickness and plight of their own little angel who had just arrived. Oh nation, tell me how they would have escaped their own saddening heartbreak when they came to know the pain I was about to go through, the cost that was beyond this pocket. Alas, then they choose poverty over middle class income and respect over begging by selling off roof and taking off siblings from the school. O nation, where is your UN Convention on the Child Rights that no child must be denied right to grow, study, and become best and bright? O nation, can you pay my surgical bill or the cost of the prosthesis? Can you give me the assurance of insurance? Can you fight with me against discrimination? No. Why? I can't walk 2 blocks anymore. My feet are swollen. Can you give me just lower berth of train? No. But why? Oh, by laws, I am not proven disabled, but I can't even breathe. My heart is racing, yet the doctor said my cardiac output is lacking. Lo and behold, I am not disabled, you say, that I must refrain from support seeking. O nation, live up to your image. Take me your social security net. I want to be rising and shining like a sun. Please take away these nasty clouds of neglect, obstructing my potential and strength. Thank you. Then I start with my slide sharing. So today you have given me a topic, rights of a child with CSD. So United Nations Convention on Right of Child was adopted in 1989 and entered into force in 1990, and India ratified it. So there are 54 articles, but most important is core principles are that a child should never be subjected for discrimination. Best interest of child vulnerability should be taken care of. The right to survival and development is there, and we have to respect the views of child. So accordingly, our children with CSD are not, but they are very well protected under these articles. So Article 12, 28 and 19 and 29 and 31, they are very important. And the most important is Article 23, which says your right to special care and support if you are disabled. So there is a convention and there are some provisions, but did we make a use of it? No. There are a sea of issues with the congenital heart disease, medical bills, a second surgery, marriage, sports, employability, health, life insurance, social security, and who will offer option. We need a stepping stone This is my program, Spandan. I started in 2003 and converted it into extended family. So many of you are father or mother of the children with the congenital heart disease, but I have also a very big family of children who have congenital heart disease, who were born around 2003, and now they are going for marriage. They are looking for a second operation. So I understand what are the issues they are going through. This is my story where you can see the paper after paper I kept on writing on the disability document criteria for cardiac disability. This you can see in 2009. I wrote a email CSD about the disability. You can see the topic is disability in 2009, and I had no primary criteria or anything anywhere. So I was just kept on working, and this was the first email was done for the Professor Rajan Tandon, who was father figure of pediatric cardiology, and he called me and we discussed again, and he told me what wrong I was doing in my document, and I corrected that. I also wrote a mail to other people, and the most important mail was written under the behest of on the behest of Dr. Rajesh Sharma. Then I discussed the issue that there was no hearing about this topic. So this I wrote to PCSI President Dr. Krishna Kumar, based on his own paper, that calculated need of cardiac surgery program getting fulfilled. What we achieve is 200 center with capacity to operate 1,000 patient per year. Will have approximately we will have 20,000 plus number of patient per year, and around 2,80,000 pooled patient as adolescent and adult patient after average 14 years of uh, uh, 14 years from this date. So they will be looking for a respectful place in society, craving for a fruitful life, job, marriage, children. How would they know that they are disabled or they are able for the various responsibilities they are going to own? So this was the thing. Then we actually made this paper. This paper was on these questions. We made this paper. Dr. Rajesh Sharma, who is now president of PCSI, is my co-author, and we wrote this proposed method for evaluation and categorization of functional capacity of children, adolescent, adults with cardiac disease to bring them in existing social justice system by creating the cardiac disability criteria. So we must know that stepping stone, what I showed you, the Ram Setu picture, this is a small effort to create that is stepping stones in the further for the evolution of further social security system. So highlight of this paper where because there was emerging epidemiological trend in India indicating the rising burden of cardiovascular diseases, and the most important development in the history of disability was that dynamic nature of disability was accepted, and that's why the diseases like thalassemia were included, and you see them in the latest Disability Act. So there is a need of social support system. Yet the list of 21 benchmark disabilities, this 21 came after 7. So you know the people actually worked for their own fraternity. So 21 benchmark disabilities notified by the Department of Empowerment of Persons with Disabilities, Ministry of Social Justice and Empowerment, Government of India does not include CVD under the newly enacted Right of Person with Disabilities Act 2016, while the RPWD Act 2016 has acknowledged that dynamic nature of the. So here we missed the bus. We were working on this from 2009, 2011, 12, 14, 15, but we were unable to get any entry in this bus because there was no proposal from the pediatric cardiac or maybe cardiology fraternity. And we must know in 84 there was a disability criteria, a short disability criteria was proposed when the first disability document came up, but it is nowhere now. So we tried, but consensus was not achieved, and that's why we are here and struggling and moving nowhere. So aims and objective of this paper were to define the cardiac disability. What should be a baseline criteria? Because there is the one reason why cardiac diseases cannot be categorized in various disabilities format or ability format, because there is lot of veracity in their presentation. A small VSD need not to get any surgery. A large VSD which was not operated on time is inoperable. A multiple VSD may need a PA bending instead of total correction. So there is lot of veracity, and there was reluctance for the time. The second thing is lack of awareness, reluctance of the timely referral by the pediatricians, and acceptance for the surgery by the families. We saw the Aisan Menga in well-to-do families. The all financial assistance given by the government is is undervalued the type of procedure, and that's why the quality of procedure cannot evaluated. The machines cannot be upgraded if this much amount is allocated for the cardiac surgeries, because it's a big thing. And most of the schemes, they don't take care of extended hospital stay, comorbidity, and all those things. Then there is no medical care for the cardiac patient operate. Like a patient is having meningitis and was operated by TAF. So many times the people will deny any hospital admission in the local place and will say go your tertiary care center. The cardiovascular disability is not a specified disability, so the fund allocation is also not available for the cardiovascular diseases. There is a apathy for the psychological issues, because as a first step we are not recognizing the issues related with congenital heart disease or heart defect. Then why we will look towards the other thing, expanded collateral problems along with this. Then there is a issue of the life and health insurance, and we must know these kids are, I am not trying to make you more worried, but yes, the adult onset heart diseases, these group who underwent the surgery or intervention for a congenital heart defect are a special vulnerable group. So they need to have some security over there. Denial to avail normal opportunities despite a normal functional capacity. This is also a big problem. They are prohibited from the participating in competitive sports. Again, landing a issue in the psychological health. And there is a chance of the sudden cardiac death also. There is no chance of sudden cardiac death. There is a classification of sports. Certain sports every child can play, certain they cannot. There are pregnancy related issues. Surrogacy is a real great option. These are the things which we need to know. We have to categorize children so that we can provide them the type of sports they can play. It is not a blanket. I mean, what I mean that a blanket statement on the schooling, sports, reoperation, marriage, pregnancy, longevity is totally unfair. That is the most important thing I would like to say. So what are the things we must do? This is a chart I sent for the government also, that pre-conception, we have to be very careful about our nutrition, because diabetes mellitus, obesity, and the periconceptual radiation exposure, all those things are high risk factor. Folic acid deficiency, that is a proven fact. The congenital defect, including the heart defect, it can be there. And smoking, there are many other things. So we have to be very careful about the preconception counseling, particularly for diabetes and obesity. Then first trimester, I really want that we have to hit it hard. The moment pregnancy is declared, we should start getting a health insurance scheme at this point, when you don't know a heart is normal or abnormal. And if we go for less than 3% birth defect, less than 1% chance of having heart defect, and if we go for a optimized healthcare package in the first trimester, so second level ultrasound will be promoted, and a termination can also be done with more surveillance. So first level, and the insurance companies can be recruited into it, and optimized package can be done. There is no other time in pregnancy where you can think of a health insurance for a congenital defect. So we have to talk in unified voice about the first trimester health insurance. Then post conception, there we know what are the problem: early detection, pulse oximeter, availability of prostaglandin, and a right place where you can go for a surgery, and optimization of the CGHS ESI packages, Ayushman packages, so that every hospital can be part of the PPP. So this particular document, it has a table A, B, C. Table A has no or mild hemodynamic abnormalities with the least chance of progression and intervention. Table B, significant hemodynamic effect, high chance of progression and intervention. Type C, significant hemodynamic abnormalities, intervention required if it is possible. So it is almost like a Eisenmenger syndrome. You keep them in table C. And then every table has been divided into: one, the heart disease unoperated; second subgroup, heart disease where operation was done, like a VSD closed, no problem, then it becomes a type table A. But if it is a cardiac dilatation, a valvular regurgitation, a pacemaker implantation, then it goes in table B or C according to the disability. Then systemic, presence or absence of systemic arterial hypertension, and the pulmonary arterial hypertension, presence or absence of arrhythmias. So this is a very, very elaborate table have been made in this particular paper, and I am going for a web-based calculator also. So you just go through it and you will find your disease. Definitely, I don't think anybody can miss the particular disease. And you know the after that a functional capacity evaluation is needed or not, a disability certificate is needed or not. So those things can be done based on the calculator. This is a brief flow chart based on which how the cardiac disability can be calculated, which is though there is no cardiac disability as of now in the legal terms, but whenever government is ready to accept, we have a architectural classification over here, and we can provide a baseline which can be modified. So the conclusion of my today's lecture: the rights of children with congenital heart disease, tenets of UNCRC are applicable but never been asked for due to absence of architectural baseline structure which we can offer to government, that you do disability certification based on that, you do insurance based on that. We didn't have. But right now we have that. Health insurance for children, first trimester, insurance of pregnant women is the only way. Because after that, if you are going for an insurance second trimester onwards, it may become a targeted. Once a person is diagnosed to have congenital heart disease, they will go for this health insurance, and that will not be helpful. And like the recent Star Health insurance, health insurance program is coming up, and in 2-3 months it will be floating. But what it says they will do a second level ultrasound, and if it is normal, then only they will offer a health insurance package. So it is like that. So extended warranty on the hospital package there should be, because the people who are paying out of pocket, what is happening in 7 days, 10 days back, they are not able to complete their this thing. And it is if the hospital package is extended, then they have to pay in really very high terms. So there should be an extended warranty package and insurance system where if you are going beyond a certain period, then you can actually optimize your cost. Then consensus on CSD pre and post op, which need to be treated at par with the children without heart disease, because a person with a small PFO should not be discriminated on the marriage, on the sports, on the job profile, anywhere. Or a patient who is totally normal now and was operated for PDASD, VSD, no valvular regurgitation, no dysfunction, should be treated at par. Formation of a combined national birth defect council for rights of children is very important, because if Indian Academy of Pediatrics comes together and the various bodies. And when we talk about birth defect in single voice, then probably we are more successful. Approaching media to publish troubleshooter issues based on the article time to time. So how first trimester health insurance work? Incidence is less than 3% for birth defect. No targeted insurance if we are doing insurance just in the first trimester. If premium can be customized, it can widening the insurance net will help. It will promote a second level anomaly scan to improve the quality of government sponsored intervention program. There should be stopping CGHS, ESI, ETC direct financing scheme. Rather, it should be done like corporate, like group coverage. For the government employees also, government expenditure will go down and the people will have better care with the such kind of insurance facilities. And the government must provide high-end insurance coverage instead of under-evaluating a procedure. That is a very important thing. CGHS, ESI, Ayushman needs to be optimized. Thank you so much. Here I finish.
Thank you so much, ma'am. Thank you so much, ma'am, for the elaborate briefing on the different things that we are looking at when we are talking of insurance and job opportunities for the CHDs and all. But as of now, is there anything that we can actually go for, like an insurance or inclusion in the job? I mean, inclusion in the Disability Act. Is there anything as of now?
Disability Act, you are out. Right now, I talk to disability commissioners and the office and everywhere. Unless it is included, disability cannot be provided. That is the one. It will fire back. If you are asking for something, they will actually take away your job. So that is how it is. If you are saying I'm not able to do this thing, then people will say, okay, you are disabled. I have seen this happening. So that is the one part. The second part is about the insurance. So one thing is there are many insurance agencies who are providing insurance for the accident and all other things other than the cardiac reoperation. That is one. I asked Tata AIG and Max Bupa, and there are 2-3 other Reliance. So if you are giving premium for 2 to 3 years, so few of them will cover the pre-existing illness. So in that case, ASD can be covered because ASD, the time of surgery is around say second, third year, or maybe VSD, PS physiology, where the shunt is very balanced. So in those cases like pink top, they can be operated beyond the 3 years. Then probably they can be taken into this group. So actually, I talk at personal level, and the Tata AIG group says that we will, whenever there is a need arises, please inform us, and we will take care of that. After 3-year premium, a coverage can be given. So there you can probably contact me, and I can give the number of the particular person. So that probably can be done. So okay, that is what it is.
Thank you so much, ma'am. Because just now my request for insurance got rejected. Like I had opted for my son, and initially they said that it is inclusive and it was Star Health Insurance. All the documentation, everything actually contained that CHDs are included. I mean, pre-existing conditions are inclusive, and that congenital heart condition is also inclusive. But when the form was filled and it was filled like CTGA, and the PA banding was done, and he has got COVID recently. The medical team, the response I got from the insurance company was the medical team actually rejected his plea. Now, I mean, medical team would be comprising of doctors, right? So is it like
doctors will reject it? I'm telling you, there is so much bias against, because this paper, I have struggled so much. Like if I submitted it for the publication 2019, total 1 year I kept on writing they kept on saying me, why you are doing this? This is not required. This, that, there will be so much of burden on the government. There was lot of this struggle was coming from the doctors only. So, this sensitizing them is a very difficult job. And the thing is, what you said, I was expecting this, what you said me, because there has, that is the reason. If you see this paper where we have written the methodology, what happens, the insurance is totally in India is a individual discretion. A person to whom you are, if you know a person, probably you will get a insurance for a more severe disease. And if a person is not known to you, and if he is not ready to favor you, then they will not provide you insurance, because the insurance in India is around hardly less than 10%. And that is not very successful, because most of the time people are having targeted, my mere coronary artery disease detected, I will go and take a insurance. So that is why the biggest culprit is government, who has started CGHS, ECHS, this, that. They are giving direct, the maximum number of people who can pay, they are from government services. Either during the service or the post service, their families are included. So the biggest number of people who are having money to spend, they are the government people. So if government people are coming under the government direct sponsorship scheme, any other this insurance scheme cannot be successful. So the more, and they are also suffering because the optimization is not there. They are like bare metal stent, they will get only that. They will have a, like a minimal access surgery is available, but they have to go for open sternum bypass, because the minimal access, neither they will allow that a person pays by himself. They will not allow you, and they will say only government, whatever is package given, within that you have to work. So that way they are in great disadvantage. So and if you actually go for a corporate like group coverage, then the premium package is quite less, and we all in the corporates, we are covered by that, and we are very happy with our insurance facility. And if it is done by government, then the whole India will change, because then the insurance agencies will be more and more, they will be more kind. And the other thing is, LIC and the government agencies, they are having so much of money, they are very particular in, they are very smart in denying the claims.
Yeah, they
So
would.
that
They
is
would take
also,
that one.
they are
Yes,
very smart
LIC
in
wouldn't.
denying claims.
Yeah,
Yeah.
LIC
So that's
wouldn't
why they
allow
have
that.
thousand and thousand, I mean, not millions of the rupees sitting over there, and
That
they
is
are
what
not using it.
policies are there, things are there, and everything is for the rich. The middle class who pay the taxes to the maximum, they are like given hardly anything, any chance at life. It's really disheartening. But yeah, I mean, we'll push
Because
the
middle
matter.
class has
Yeah.
I am just, I'm telling you, I'm talking to so many people all the time for last 10, 12 years. Because, but this is so difficult to find a person who is a policy maker in the insurance agency. I'm not able to. Just now, yesterday, there is a good news. I talked to someone, and she is saying that probably if I create a good document, so she will take it to CII. And that is the first good news I heard yesterday.
That's really nice. Let us look forward to it. Thank you so much, ma'am.